another question? Yes, Dr.
Yeah, I'm concerned about the age range of your patients.
The age?
The age range, the
Age
youngest
range.
to the oldest.
Yes.
Yeah, how is it?
Age. Most of our patients are aged. University students are over 50% of our patients, university or college, either anaendelea or they dropped out, but they are so 20s. Okay. Then we get outliers. We can get late 30s, and sometimes we even get 50s. Right now we have a patient who is in his 50s, so we get those ones. And then we also get young ones. We can get like 15-year-olds. That's in secondary school, Form 2, Form 3. They are brought in by their parents. They're starting to experiment. Some of them are deep into it. But the majority are usually in their 20s and early 30s. Males are more than females, but we get females as well. Alcohol is number one in general, but for that band of 20s, 20 to 30, alcohol rarely comes alone. It comes with weed, and so weed is an emerging problem for the young people. In fact, we have those young people who tell you, alcohol is kitu yangu, mimi mtu wa weed. Okay, you had a question.
Yes, so my question is, in your here in Fountain of Hope, you find cases whereby maybe you get a client, and when you dig his or her family background, you find that maybe the problem started from the family. Maybe it's the dad or the mom who is the addict. So do you do family therapy, or you start now counseling the parents before you go to the client? Yes, how do you do it?
That's a wonderful question. She told you about our YouTube channel called Dr. BMS. We started, let me start there before I come to your question. We started this channel because, like I said, we found out that you cannot solve this problem by just sitting here and waiting for people, sirens to come, ambulance. The problem is so big. You have to educate people out there and just stop people getting into this thing. So we started it mainly for public education, and it's active. It has videos that we make, which are very educative. Some of them can even help you do a homework, a school assignment. So I would encourage you to go there. And also, if you have a message you find compelling and you can record it before you start your own channel, which I think is a good idea for you people in communication, in community development, that's something, because now people are going digital, so that's the space. Meet them where they are, that kind of. So on that channel, I would encourage today, go see a video I posted, I think yesterday or the day before yesterday. It's titled, "You Drink Too Much Alcohol Because..." You will see what we are talking about. It's under there. So in this video, we have categorized common reasons why people take alcohol. And one of them is the question you've asked. Some people are into addiction to drugs and alcohol because they have come from problematic backgrounds, family. So the family of origin can be a great determinant. If you come from a family we call dysfunctional and broken, then you are likely to indulge in this or other antisocial behavior. And this dysfunction breakage could be divorce at an early age. If your parents divorce at your age, it's mbaya sana. But when you are young, you really believe in your parents and you just want them to be there. So to see one the other side and another one the other way, it traumatizes the children. So it could be divorce breakages. Sometimes it could be neglect. Children are neglected, left with minders who just don't, so they don't see their parents. It could be abuse of various forms, verbal, physical, sexual, or emotional, all those can be, okay? It can be because of natural calamities like war. Now you see what's happening in Gaza, in Israel and Palestine, those kind of things. So yes, family contributes a big thing, because when a child is growing, there is an age when they believe that their parents are heroes. I have children. The youngest is 11. Others we have to calculate a bit. And the second youngest is in Form 2, 15, thereabouts. He's a girl and a boy. The boy calls me Superman. And even if he was here and he was not conscious, you will just see him referring me Superman. Okay? And because he believes I'm Superman, I can solve all problems. Okay? And he started calling me Superman. Then his older sister said, okay, now if you are Superman, I'm Supergirl. So now her name is Supergirl. Now these nicknames are because these children believe their parents are just that thing. That is usually an age. If you read developmental psychology, development stages, toddler, whatever, that age from around 6 years to 12 years is a critical age where a child's world revolves around the parents. The parents know everything. They can solve any problem. If they go out playing and someone hurts them, they run and report, Mommy, and they expect you to solve it. So now, if you are not there, because of separation, divorce, whatever, you can see this child has nobody to idolize. And because nature abhors a vacuum, they'll find someone. Na kama huyo mtu ni wa madre, sasa si ndio hivyo. So that's it. Any other question? Yes, sir.
In terms of the effectiveness of your program, I've heard of the 90-day program. So are there instances where you may feel like we need this patient needs or this client needs to be here for an extra period of time, and if not, then what helps you determine that the client has maybe changed or has started changing?
Okay. So those are two questions in one. How we determine the duration and what makes us see that change is happening. So let's start with the duration. First, what you can say, evidence-based science. You know evidence-based science, okay? And worldwide, it's been shown that rehabilitation from addiction, the minimum period for it to be effective has been set. And generally, it's averaging 90 days. So that's what the Ministry of Health and NACADA, which is the regulating agency, recommends, okay? So we start from there, and this is science gathered from experience around the world over a long period of time, okay? However, the period that is normally stated is always called the minimum. So these 3 months are minimum. That means if you can add something on top of it, then you are better off. Any extra day is good for you, okay? Now, we've retained that minimum in Kenya because of our socioeconomic status. It's expensive to keep these people here for families and whatever. But in countries that are able, rehab is 6 months, 9 months, and that is quite the standard. So the duration is set based on that, but because it's minimum, when they come to us in our assessments, we can recommend longer than the 90 days for some of the patients. And some of the things that make us recommend is you are having addiction and another mental health problem. You have depression, you have addiction, okay? You have psychosis, schizophrenia, and you have addiction. So these are two things we are treating in one. We recommend a longer period of time. It could be that you come from a very dysfunctional family. You are brought in from the streets. So without even digging into the history, for you to go into the streets, there is a problem, okay? Or you are coming from the criminal justice system, the juvenile courts or those probation service, 16 years and already coming with the police. That says there's a problem. So when we see that there are extra problems, then we will recommend that the period be extended. Sometimes we would recommend because the patient has taken longer to settle. You see, there are those who are brought in and they are unwilling. So they can come the first day and they won't talk to anyone. They're just like this. And they tell their parents, kama unataka nikaa hapa, nitakaa hapa miaka moja, wewe haribu pesa zako. Na nikitoka hapa ndio nitakunywa zaidi. So you see they are resistant. Now you have to spend time trying to get them out of that resistance, to be willing, and you've wasted time, so you will add on some time like that. Okay? So those are the things that guide us. Then the question of how we see that you are changing, let me answer it as a layman first, then as a doctor. As a layman, I will say, unaifeel. Mtu kama anaanza kuchange, unaifeel. Because you see, you knew where this person was. Okay? They were negative, defiant, antagonistic, vita kila mtu asikizani, you know. And suddenly you are finding out they can listen a bit. So there's that feeling you can get because of the experience you've had with this person. But objectively, now as a doctor, we have tools that will measure the change in a person. From the biophysical to the mental, and even beyond mental, the spiritual, social. So for example, you come in, you have severe addiction, you have addiction malnutrition. Addiction malnutrition, alcohol malnutrition, these are a state where you're drinking, not eating. So when you come, we can just see like you're malnourished. You're either thin, your tummy is swollen, miguu, macho imepop, hair is sparse, brown. And now as we restore you, you can see, hata wazazi wakuja, ameanza ku add weight kidogo. So that's on a biophysical level. You can see that the indicators and laboratory tests you did when they came, they are living or in the middle, you can see. Then mentally, you can see a person's thought process change. Because most of them, if you heard what Peter said, when they come, they are like in a daze, like they cannot connect dots. So they cannot engage in any discussion that is serious about a concept and continue. But after a while, as they change, you can see they are starting to have more concentration, more participation in what is happening. They are starting to have new ideas, okay, new awareness, and then you see that mentally now they are coming back. They are starting to get engaged. Then mentally also, from a psychiatric point of view, they may be having delusions. Mtu mind yake tu iko wild, anafikirianga tu hivi na hivi. Now you can see those wild thinking and patchy, whatever is coming back together. You know that they are improving. There's also improvement we see even on a spiritual, spiritual level. You come and you have kind of weird belief, I don't care attitude. Kwa nani hata kufa? Kama ni hivyo, you know. And it's like you don't care about what other human beings care about. And if we bring in even the issue of religion, sasa hapo ndio hata tumetupa mbao sana. You are not there anymore. So you find this person now starting to be caring, to worry about the future, to want to achieve some things, to aspire. I would like to do this. Then you know now their spirit is coming back, their humanity is coming up. And some of them even become religious. By the way, in our work here, we integrate a lot of spiritual health. I mean, the 12 steps, if you've not studied, that could be, because we wapatia homework to do something on the 12 steps of rehabilitation. You will see it's based on spirituality throughout. And so the spiritual component is big. We get even church ministers coming here to minister to them. And some of them agree to be born again. Some of them confess things to the church minister more than even to us. So the church minister is also a counselor and will team up with a one-on-one counselor. So you see those changes along those lines progressively. Yeah, okay. Any other question? Watu wameketi, wamechoka. Haya. Do you believe what?
she addicted to alcohol, because he or she is cursed ama amerogwa kutumia hiyo pombe. And if you have found that
Okay. Wow, that's an interesting question. I must say I've never been asked a question like that. It's very interesting. Because what you're asking, the interaction between what you can say the occult and what we can quantify in science. What is extra science and science? For us here, I must say, our premise is in science. We try to use scientifically endorsed and evidenced approaches to therapy. But we are also cognizant of culture. And we know that in our culture, you can have people who believe they are bewitched, or there's a curse, or something has happened. Now, when we realize that there is a cultural element in what the patient is experiencing, then we take it on board and we approach it mainly using our scientific, which is psychotherapy, counseling, and then the established religious approach. So, for example, you're using drugs because you believe you are cursed, and so you cannot escape that curse. Okay? How we will approach this, we'll want your family to come in so that we explore a bit more about this curse. This idea of curse, is it just your own idea or it's shared? Because when it's shared, it's likely to be very deep-rooted. If it's just your own, then we start to think maybe you're having delusions, you know? And if it's delusion, it could be something mental like psychosis, like that. If we find it's rooted in the family, then we want to understand, because every curse in the family has got an explanation and has got something that needs to be done. Maybe it has not been done, but needs to be done to take away that curse. Some sacrifice, something, whatever, you know. Even if someone bewitched you and they are dead, some cultures say you have to visit that grave and do that. So for us, we will encourage all those things that need to be done from a cultural point of view to be done, because we know this will be healthy for your mental or your psychological health. When you start believing you are cursed, and then now you believe the curse has been washed away, so now you will participate. So we take on board anything and everything that comes, but we always want to manage it from a science-based. We don't just want to propagate it and then we don't offer solutions. I hope I have answered you. Yeah. Yes?
Apart from drug addiction, how do you deal with other forms of addictions? Na kuna mushawahi kuwa na cases za hizo addiction?
Thank you. Actually, we are overlooking behavioral addictions even as we talk. On that Dr. BMS channel, spend some time on it. You will see videos that talk about behavioral addiction. I posted one last week or 2 weeks ago. It was talking about problems of millennials, kama nyinyi, Generation Z and millennials. And I said, for males, millennials ni watu walizaliwa tuseme from 1990 mpaka saa hii. Okay? So they are like 30 something downwards. Males, the new emerging problem is gambling and pornography. Gambling here, betting here, mpira, nini, and then it links into drugs. And females, females have not posted, but now I should post because females, mainly social media addiction. You want to be a star. Okay, so hii ya picha inaitwanga nini? Na postingi picha? Instagram. Yeah, you post it. And you want likes and what, and you have stars. And some girls have taken it further to what is called fans only. You know what fans only? Who doesn't know what fans only is? So you take it that, so it's the new thing. Eh? So yes, we have addictions that are chemical addictions, alcohol, marijuana, heroin, mirror, amphetamine, blah, blah. And then we have what I call behavioral addiction. Pornography, sex addiction, what are the others?
Gambling, exercise,
Gambling,
working.
shopping, gossiping addiction. All those. And rarely do these addictions come alone. As you can imagine, when you gamble and you win that bet, so utaenda kuhappy. Utanua mzinga. So you'll come with the alcohol and gambling. Okay? So we get them combined, and the approach is the same, general, but specifics. Because the science behind addiction is that something has happened in your brain. You always get this rush. We call it a dopamine rush. Dopamine is a chemical in the brain which mediates happiness, the high. Yeah? It's one of them. We have others, but it's one of them. And so you've gotten used to having like a rush. Yani, it could release through in huge quantity, and you just like, wow, wow. Now, someone who's not having that high can wonder, kwa nini nachekesha huyu mtu? Because kila kitu it just seems to be fun and nice and happy. And that's right. The science of addiction is that you use substances or you engage in behaviors that trigger this response. And so if it is addiction to like gambling, yani saa ile unafungua hiyo computer hiyo bet, already you are shaking with anticipation. Mazee, ukimagine tu vile utawin hiyo do, you are already just salivating. So the science is the same, and so the treatment is reversing this science. And we reverse that science generally by psychotherapy. We make you aware that this kind of thinking is what is causing you to get into these problems, and this is what you can do to reverse. And then now we have got treatments that are medical. We have medicines that you can give just to prevent that build up of that dopamine. And so that's what we do, whether it's behavioral addiction or chemical addictions. Okay? Another question? Yeah.
Maybe to one.
We will now, we are at 1:30. Daktari, we can allow some 5 more minutes, then we... Your heart was choking, sir. Yes.
Okay, I'm asking, what is the maximum number that you can handle?
Yeah.
And maybe in the winter in the work, for instance, if there is a situation that is too difficult for you, can you refer to another person around the institution?
Thank you for that. Yeah, our capacity here, Fountain of Hope, is 25 at the moment. We chose that number deliberately because if you go around some rehabs, we will go to the rooms and you will see. You go to some other rehabs, you got on a double decker. I don't know, like you. The numbers you can just, that 25 you can push it to 15, you just go like carpenter to make more beds like that. So our capacity is 25, and we chose it deliberately because our experience has shown that the work of rehabilitation is very intense. You have to get involved and know each person very well. Umeona kuja hapa, ukiona nikiwaita Peter nani. I know them na pia wananijua. They come to my office. Sometimes when I come in, they just, daktari hata ninunulie soda tu. And tumekuwa kama mabeshte, unaona? So you have to engage that way. That's when someone can really come and tell you, kwa moyo wake, nini inamsumbua. And you can't engage when there are many, because watakushinda. And so when there are many, some will just flow in. And someone who can just pass through that 3 months, hata hujamjua vizuri, anapita tu hapo. Okay? So that is our capacity. In terms of referrals, yes, we refer. We collaborate. If we stay here long enough, this psychiatrist, our resident psychiatrist is coming. He will come to see patients. So we call specialists who come in to see. We refer some patients who maybe are not making progress well, or some of them, something has happened between them and their therapist. You see, in counseling work, you have to have a relationship of trust and mutual respect with your counselor. But if you start feeling, huyu mtu anisaidii, then it is gone. Remember I told you, if it's malaria, I don't need your, I just need that vein. But this one, you must have that. So if you find, for example, a patient is expressing like they're not feeling like they're getting what they need, even if we think that's not true, that's reason to refer. Okay? We get some patients who are very sick, they need intensive approaches, like maybe they have mental health disease, they need like ECT, you know ECT? Electroconvulsive therapy, napigwa shock. Kama madhare, uja ungine, chizi kabisa napigwanga shock. To try to, reset the brain. So we get those ones that require interventions we cannot give, we will refer them. Some rehabs have got a cell. Kajela. Mtu akikuja amechizi kabisa, tutakufungia hapo, uko kwa cell hapo. Wengine wanapigana, sometimes they fight here, whatever. So if we get very violent patients, we don't take them ourselves because we don't have those facilities. So we can refer because we can't handle you technically, we can't handle you administratively, because yourself, you have expressed a reservation about what is going on here, like so. And also we refer when they have problems that we can't treat, like some come with dental problems, so we'll take you to a dentist and then you come back. At the end of the day, we want the patient to be cured and we want to take care of all the problems that they may have. Okay. The last question, yes?
So, when was the institution started, and maybe what their motivation for starting the institution?
Kara wewe kupatiana history. Okay, Fountain of Hope. Fountain of Hope, the very idea of Fountain of Hope started in 2012. And the person who started this, one of them is my wife. Okay, she's a clinical psychologist. So she was in training at that time. She had finished her first degree as a counseling psychologist and now practicing as a counselor. And so people would come for counseling, and you notice a trend, like young people particularly, parents will bring their young children in secondary school or in college that they're not doing well in school, they're dropping marks. But then as you continue, you find that actually this young man or this young lady is using drugs of addiction and parents don't know. So it becomes a shock, then another one, a shock, then a shock. And each time they ask us, sasa tutafanya nini? Now where can we take? Then we realize again the places to take the matter sio nyingi. The places that were there, like around 2012, even up to now, some of the places are run by people who are just recovering addicts. The only qualification you have is that uliwahi kuwa mtu wa madre na ukawacha. So kama uliwacha because muujiza ulikufanyia, Yesu alikuonekania ama nini, then you believe kila mtu Yesu atamuonekania. Na mwenye aonekaniwe sasa unaona you will not take care of them. So we thought now, okay, let's get into the science of this. And so we started Fountain of Hope. Initially we were doing it in a Kikuyu town, just some place. Then later on in 2017 we came here. But throughout all that time we were doing it. So this inspiration was that experience of meeting people in need and finding that what they need is not there, you don't know where to connect them, and then also that the practice that was going on sometimes was not scientifically based. And so we started, so we teamed up and brought in more people, because now we have clinical psychologists, counselor, but then we needed doctors to come in, psychiatrists to come in, spiritual leaders, ministers to come in. So later on we brought in all these people, and now this is what we have. Today, so we have, I am the managing director. My background is initially medical, daktari wa hospitali, and then now I branched into this area, but carried those skills. Okay. We have psychologists, counseling psychologists. This one, that one seated behind wengine wako. We have clinical psychologists, we have psychiatrists. Those ones usually they come on a needs basis. Mgonjwa akiwa anakuja wanamuona na wanaenda. We have the spiritual ministers. They usually come also on appointment. And so we brought all these people together so that you can deliver the full package of treatment. That's what we do. We do what we do. We don't always succeed. Maybe that's a question someone will ask. We don't always succeed. Slightly over half of our patients who come, they will recover on first attempt. But about 4 out of 10, 40% will relapse and need to be rehabilitated again or something. And still, even out of this 40%, about half will serially relapse. Okay, so you can meet people who can tell you, nimekuwa rehab zote ziko hapa Kenya, I know everything, na naongea akiwa kwa hapa anakunywa. But we have also those ones who have changed their ways and gone. And sometimes one of our greatest happiness is to get invited to a wedding, or to see a picture of a newborn child on our alumni WhatsApp. Kuna wale sasa ameenda na ameolewa, ameoa, amepata mtoto, and they post there, and we send flowers and whatever. Yeah, so there are those who get well, but there are also those who struggle. What determines? I don't have an answer per se. Only God knows. But we've seen you are likely to do well if you've not gone too far. If you're coming from a stable family, you remember I talked dysfunctional, broken families. If you're coming from a stable family and the family is there for you, hawajakuja tuna kurusha hapa na wakaenda. They come in and they engage, and that when you leave, you have things to do. Uko koleso, ukirudi unaingia chuo, ama uko job unaingia hustle yako. But if you leave and just go idling there and whatever, then sometimes the temptations can overcome you. Higher.
I had one last question.
Okay.
My question is now, you have been in the field for a long time.
Yeah.
You have a lot, maybe, of experience. And for us, we are learning some of these skills. My question is, what are some of basic skills that you can see this skill and these principles in counseling will give you a breakthrough, will just help you maybe come up with a client who can change their mindset, or whom they can change?
Okay, thank you for that. I would start by saying this. Counseling, I could say it's the oldest engagement. I don't want to use profession because that one may say others exist, but it's the oldest engagement known to humans. And vile tuko hapa wote na wenye wako huko nje wapi, everybody is a counselor. Niambie tu nyinyi vile mko hapa, nani mwenzake rafiki yake hajaye kuja kumwambia sasa hii kitu sijui, na ukaanza kumwambia ukafanya everybody is a counselor. So it's a natural thing to all humans. You listen to someone, you share your thoughts, they share theirs, you agree, disagree. That's the basis. So the first skill you need to be a good counselor is just the ability to engage. Listen. Sikiza tu huyo mtu. And don't start judging. Don't start expressing anything, verbal and verbal. You see, now you have already expressed your reaction to what happened. And some of them are sensitive. Now they know. Siwezi kumwambia because kama atanichukulia vibaya. So you be a good listener. You be a listener who can be passive on purpose. You hold your emotions. Unasikiza. Okay? When you start to engage, you ask to clarify something. Okay? At the end of it, you don't rush to give a judgment. In fact, you don't need to give a judgment to make a pronouncement about something. What you need is just to shine a light, to ask a question about something that you know in your mind that this is problematic. So it does not mean when you are a counselor, you have no mind of your own because you don't criticize. You know what is right and wrong. But it's not your work to bring out what is right and wrong forcefully, because remember, this person has been told, hiyo ni makosa. Hiyo kukemewa, huyo mtu amekemewa, so wewe sio wa kwanza. But you can just shed some light on it and let them realize that what they did could have been done differently. So you can ask, sasa vile ulimchapa kuliendaje? Tuliachana na akaenda. Sasa vile ulikuwa umeenda akupatie kitu fulani, ulipata hicho kitu? Pata. Sasa utafanyaje? Just by asking those questions, you've not said whether what they did is wrong or right, but you are making this person focus on the consequences of their actions. And sometimes some of them just say, I think singefanya hivyo, maybe ningengoja. And then now you just use that to tell them, okay, but that's a good idea. And I think when you get another chance, now it's wise you don't rush to do it. So that's a good skill. And another one I'll talk about, because there are many, I could just talk about two. The another one I'll talk about, you have to be grounded family, wewe mwenyewe, intellectually and socially. Because you cannot counsel someone when you don't know about these things you're counseling about. You're talking about, you meet a young person lost on social media, na hata hizo social media mwenyewe hata usijui. Sasa utacancel aje? So you have to read books. Mwende library msome. Don't just Google. Every answer comes from Google. You have not read, you will not be a good counselor. Okay, I think we can end it there. Thank you for your time.